All right, everybody, we're going to get started. My name is Brantley Hudson. I'm a P4 from Stanford University, and today I'm going to be talking about RDS and BPD, respiratory distress syndrome, and bronchopulmonary dysplasia. Respiratory distress syndrome is primarily caused by inadequate pulmonary surfactant, which results in diffuse alveolar atelectasis, edema, and cell injury. Surfactant production begins at 22 weeks of gestation normally, and lungs normally mature at around 35 weeks gestation. 10% of premature infants in the U.S. develop RDS each year. The more premature you are, the greater your risk for developing RDS. A 6% chance of RDS in infants born before 29 weeks has been noted. Other factors which increase your risk of RDS are Caucasian race and male gender. Maternal risk factors include lack or insufficient prenatal care, belong to a minority, uninsured, poverty, prior history of preterm birth, low maternal body mass, periodontal disease, and maternal diabetes. Other risks of RDS and the main risks which we talked about earlier were prematurity, cesarean section without labor, as this normally gives a steroid and adrenergic hormone release and promotes surfactant production. Genetic disorders affecting surfactant proteins can also be a cause, and genetic mutations of ABCA3 gene in particular. RDS pathophysiology is laid out here. So the deficiency of surfactant in neonate lungs causes a decreased compliance and increased risk for atelectasis. The VQ mismatch leads to hypoxemia and hypercarbia, which results in decreased oxygen delivery, aerobic metabolism, respiratory and metabolic lactic acidosis, as well as pulmonary vasoconstriction, which further leads to right to left shunting through the foraminal valley and the ductus arteriosus. The pulmonary vasoconstriction causes increased oxygen impairment. Oxygen damage in barotrauma and volutrauma lead to high FO2, which causes oxygen damage. Oxygen is a free radical and results in an inflammatory response, reduction in surfactant synthesis, increased endothelial permeability, which can lead to pulmonary edema and surfactant deficiency. So RDS commonly presents with tachypnea, intercostal and subcostal retractions, nasal flaring, and grunting, as well as cyanosis on room air. The goals of RDS management are to avoid the hypoxemia and acidosis, minimize injury to the lungs from volutrauma, fluid management to prevent hypovolemia and hypotension, and to decrease metabolic demands while maximizing nutrition. So prevention and treatment. So as far as prevention, antenatal corticosteroids, and treatment is our surfactant replacement therapy. Antenatal corticosteroids accelerate maturation of fetal lung, induce surfactant production, and are normally given between 24 and 36 weeks gestation to pregnant women who are at risk for preterm delivery. Our choice steroids in this case are betamethasone and dexamethasone. An incomplete course may still provide some benefit, and efficacy prior to 24 weeks gestation is unknown. Surfactant replacement therapy is considered to be the most significant advancement in RDS care for infants, as in 1960 there were 25,000 deaths due to RDS, and in 2005 there were 860. Studies of surfactant therapy in neonates has shown improved oxygenation, decreased ventilatory support. The first-time dosing of surfactant, or commonly referred to as SURF, remains undetermined. Prophylactic surfactant given to infants soon after birth improves air distribution and reduces lung injury. Early rescue treatment given within 2 hours of birth has also been proven to be beneficial over delayed treatment. Our common rescue surfactant therapy is given when greater than 30% oxygen concentration is required or when mechanical ventilation is required due to CPAP failure. So repeat surfactant dosing can give us improved oxygenation and ventilation, decreased risk for pneumothorax, and increased survival compared to infants receiving only one dose. Surfactant is administered via endotracheal tube. Ventilation must be briefly discontinued, and sometimes this is done via in-out method of intubation. Common adverse effects include apnea, bradycardia, desaturation, and pulmonary hemorrhage. So the 4 surfactant products that are seen, and actually there are only 3 as surfactant is no longer available, are Survanta, Infisurf, and Curasurf. Replacement surfactants are composed of phospholipids and surfactant proteins B and C. So bronchopulmonary dysplasia is the long-term complication of RDS, and the risk of BPD is inversely proportional to gestational age, neurodevelopmental impairment, as well as retinopathy of prematurity are other long-term causes of RDS, long-term complications of RDS, excuse me. So BPD is also considered the chronic lung disease of prematurity. It's a result of oxygen and mechanical ventilation used in the management of RDS, and BPD can be defined as whether or not a child receives oxygen treatment greater than 21% for at least 28 days. The National Institute of Child Health and Human Development set the criteria for defining BPD and places infants with BPD into risk categories based on birth, gestational age, and oxygen requirement. So epidemiology and risk factors for BPD include infants weighing less than 1,250 grams are at the highest risk for developing BPD and account for 97% of cases. And also, increased BPD severity is seen with male gender, Caucasian race, and decreasing gestational age. Approximately 15,000 infants in the U.S. develop BPD each year. There are 2 phases in BPD physiology. First, we have the acute lung injury phase, which is injury from mechanical ventilation. So it's a combination of oxygen toxicity, barotrauma, and volutrauma, which results in a release of pro-inflammatory cytokines and recruitment of inflammatory cells into interstitial and alveolar spaces. This inflammation is due to proteases, oxidants, chemokines, and chemoattractants. Influx of inflammatory cells follows this and causes leakage of water and protein. Alteration of pulmonary vascular tone, interruption in alveolar development, and emphysematous-like changes are seen. There's also peripheral airway obstruction caused by excessive secretions and sloughing of cells due to a compromised mucociliary transport system that does not normally clear these secretions and cells. Inhomogeneous peripheral airway obstruction leads to alternating areas of collapse, hyperinflation, proximal airway dilation. Chronic lung injury phase is the second part and involves the release of growth factors and cytokines resulting in fibrosis and cellular hyperplasia, pulmonary fluid retention, as well as hyperreactivity and increased muscularization of the airway. The result of all these changes is an increased airway resistance, decreased lung compliance, impaired gas exchange, a VQ mismatch, and air trapping. Presentation of BPD is typically tachypnea, retractions, and rales. Arterial blood gases often show hypoxemia and hypercarbia. Subsequent respiratory acidosis and metabolic compensation follow this. Also seen are structural pulmonary changes. So in managing BPD, our goals in the NICU are to minimize oxygen consumption, injury from oxygen toxicity, barotrauma, and volutrauma, and to maximize nutrition. Pharmaceutical strategies include diuretics, mainly loops and thiazides are our choice diuretics, bronchodilators, with our drug of choice being albuterol. as well as other bronchodilators such as muscarinic agents, and that would include ipratropium or Atrovent. Inhaled corticosteroids can also be used and may be considered for infants with severe BPD or who require a high concentration of oxygen. So prevention of BPD, our main drug for this is caffeine, and it gives us a reduction in BPD incidence. Earlier dosing is shown to decrease duration of respiratory support, improve long-term survival, and decrease the incidence of neurodevelopmental disability. Systemic corticosteroids can also be used to improve lung function, reduce mechanical ventilation needs, and the side effects of systemic corticosteroids are hyperglycemia, hypertension, and spontaneous gastrointestinal perforation. It is recommended to reserve systemic corticosteroids for those patients with progressive respiratory failure that is refractory to other therapies. Systemic corticosteroids, just continuing on with this, it is preferred that a short course and the lowest dose is used. They provide us with reduction in ventilator settings and facilitate or decrease time to extubation. Dexamethasone is the commonly used drug and is the most studied and widely used per the protocol in DART. Therapy should be started greater than 7 days of life. Early treatment has been associated with cerebral palsy and neurodevelopmental impairment. It should not be used in conjunction with indomethacin, as there is an increased risk for GI perforation. Monitoring during DART or other dexamethasone protocols should include blood pressure and blood glucose. If therapy exceeds 7 days, cardiac monitoring and an echocardiogram is recommended. Therapy with systemic corticosteroids is contraindicated in patients with systemic infection. And lastly, vitamin A deficiency has been shown to be linked to BPD development. Low vitamin A levels are often seen in preterm infants, and supplementation is well tolerated and has been shown to decrease incidence of BPD. Long-term consequences of BPD include mortality rate within the first year is 10 to 20%. Infection is the most common cause of death in these patients, and rehospitalizations are 2 times higher in those with BPD within 2 years of life. And thank you all for listening, and that's all I have.